So what if the feeling that your body has, physically changed shape isn't a tissue problem at all, but a neurological illusion?
Yeah, that is a wild concept to start with. Hi, everyone. I'm so glad to be here for this.
Welcome to the deep dive, everyone. Usually when we talk about a physical sensation in the body, we just default to, simple mechanics,
Think
right?
like basic engineering.
Exactly, like a stretched rubber band loses its snap or a worn-out hinge feels loose. We always expect the physical tissue to be the sole culprit. But today, we are tackling a question for you that might feel, I know, a bit taboo, yet it's incredibly common. Can a nerve injury actually make the vagina feel loose?
It completely challenges how we normally think about the human body. Because we inherently want to believe that if something feels physically altered, well, the tissue itself must be permanently changed.
Stretched out or broken or whatever.
Exactly. But the nervous system, as we're going to see, it doesn't always play by those simple structural rules.
And to figure out how that's even possible, we are pulling from a really fascinating stack of sources you actually provided for this deep dive. We've got clinical guidelines from NICE on neuromodulation, deep dive articles on pelvic floor physical therapy, and some really extensive medical literature on a condition called pudendal neuralgia.
It is a really robust set of data.
Yeah, it is. So the mission today is to unravel the hidden connection between vaginal laxity, the physical sensation of looseness, and a frequently ignored, highly temperamental nerve called the pudendal nerve. It is honestly so surprising to think that a feeling of physical looseness could be a neurological misfire.
Okay, let's unpack this. Before we get into the laxity question, we need a baseline. What actually is a pudendal nerve?
Right, so think of the pudendal nerve as, well, the absolute powerhouse of the human pelvis. It originates at the very base of your spine, specifically from the sacral nerve roots.
That's the S2 to S4 area, right?
Yeah.
Spot on, yeah. S2, S3, and S4. From there, it travels down and it branches out to supply almost the entire pelvic region. What makes it incredibly critical to human function and honestly so complex to treat is that it's what neurologists call a mixed nerve.
A mixed nerve, so it isn't just sending like one type of signal.
Exactly. It carries three distinct types of fibers. Sensory fibers, which, provide feeling, motor fibers, which control muscle movement, and autonomic fibers.
And autonomic is like the background stuff, right? Involuntary thing.
Yes, the involuntary background functions. And once it enters the pelvis, it actually splits into three main branches to manage all of this. First, you have the inferior rectal nerve.
Which controls the anal sphincter.
Right. Second is the perineal nerve, which is huge for our topic today.
And why is that one so important?
Because it controls the pelvic floor muscles and it supplies sensation to the vagina, the vulva, and the perineum. And then finally, there's the dorsal nerve, which supplies sensory information to the clitoris, or, in males, the penis.
That is uh, quite the resume. I mean, it's basically responsible for some of the most crucial and intimate functions of human life. Holding in your pee and poop and, well, dictating sexual pleasure and orgasm.
It really is.
Let's upgrade how we usually think about nerves. Rather than just a dumb electrical cable, it sounds like the pudendal nerve is more like a fiber optic smart home system for the pelvis.
Oh, I like that analogy.
Yeah, like it manages the structural security doors, so your continence and muscle tone. But it also manages the ambient environmental sensors, like your feeling of touch and friction. So if the mainframe gets damaged, you don't just lose the sensory data, the physical doors stop holding their tension.
What's fascinating here is how that mixed nerve reality plays out in a clinical setting. Because it manages both the structural doors and the ambient sensors, damage to it rarely just causes one isolated symptom.
As a cascade effect.
Exactly. A sensory issue, like numbness or burning, is almost always paired with a motor issue, like severe muscle weakness or spasms. A glitch in the mainframe cascades across the whole system.
Which dives right into the core question of this deep dive. If this nerve controls both feeling and muscle movement, how does a glitch in the mainframe actually cause vaginal laxity?
Well, the clinical literature provides a resounding answer. Pudendal nerve damage can absolutely cause the vagina to feel loose.
Wow. Okay.
Yeah, and it happens through two distinct sort of compounding pathways. Let's look at the motor factor first. Vaginal tone, its firmness, its grip, structural support that relies heavily on the pelvic floor muscles. We are talking about muscles like the levator ani and the pubococcygeus.
Wait, I need to push back on that for a second. Muscles and nerves are separate tissues, right? If someone feels loose, why wouldn't the muscle just be like torn or worn out from age? Why blame the nerve?
Because a muscle without a nerve signal is essentially, well, it's just a dormant piece of meat.
Oh, wow. Oh.
Yeah, nerves provide the electrical tone that keeps a muscle firm and ready to fire. The pudendal nerve commands the levator ani and pubocardiagus. If that nerve is entrapped or damaged, those command signals get weak, or they get totally scrambled.
And without the signal.
Without that constant electrical stimulation, the pelvic floor muscles begin to atrophy. They physically thin out, they lose their firmness, and this leads to actual structural laxity in the vaginal canal.
That makes so much sense.
In severe cases, because the muscular hammock holding everything up has lost its tension, it can even lead to pelvic organ prolapse.
Which is where organs like the bladder or rectum actually begin to bulge downward.
Exactly.
So the physical side is very real. I mean, the muscles literally get weaker because the power is cut.
Oh.
But the sources highlight a sensory factor too, which seems like a crucial and frankly incredibly overlooked medical reality. Vaginal tightness isn't just about physical dimensions or muscle mass, is it?
Not at all. The sensation of tightness during intimacy relies heavily on what the medical literature calls neuromuscular feedback and friction. The brain relies entirely on the sensory branch of the pudendal nerve to, confirm that friction is occurring in that space.
Right.
So if that sensory nerve is blunted or muffled in any way, the brain simply doesn't receive those signals.
Okay, let me make sure I'm wrapping my head around this.
Yeah.
Is the looseness a physical reality, or is it basically a sensory illusion created by a failing nerve?
It is a double whammy.
That's both.
It's both happening simultaneously. The muscles are actually physically weaker because the motor branch isn't firing properly to keep them toned. And on top of that, the brain is receiving muted sensory signals because the sensory branch is damaged.
So the brain interprets this lack of sensory friction as looseness.
Precisely. Even if the physical space of the vaginal canal hasn't drastically changed, and because it's a neuropathic issue, this feeling of laxity is frequently accompanied by other nerve-related symptoms.
Like what?
Things like numbness, tingling, unprovoked burning sensations, or dyspareunia.
Which is painful sex. It's mind-blowing to think a patient might feel loose and just assume they need a surgical tightening procedure, to cut away tissue. Meanwhile, their tissue might be perfectly fine, but their nerve is just failing to send the friction signal to the brain. Here's where it gets really interesting. If this nerve is so important for pelvic tightness and sensation, how is it getting damaged in the first place?
Well, to understand the mechanism of injury, we have to look at the nerve's anatomy, which is notoriously tortuous.
Torturous, like it twists and turns.
Oh, incredibly so. After leaving the sacrum at the base of the spine, it twists, turns, and dives out of the pelvis. It slips between heavy bones, wraps around these thick bands of tissue called the sacrospinous and sacrotuberous ligaments.
That sounds like an obstacle course.
It really is, and eventually it passes through a very tight, narrow tunnel of fascia called Alcock's Canal.
I was actually looking at the anatomical diagrams of the sources, and it just makes you marvel at the bizarre design choices of the human body. I mean, threading a delicate vital nerve through shifting bones and thick ligaments.
It's asking for trouble.
It's like threading a delicate electrical wire right through the hinges of a heavy oak door. Every time the door moves, that wire is at risk of getting pinched or stretched or just completely crushed.
That mechanical vulnerability explains why pudendal neuralgia is classified in the medical literature as an entrapment syndrome.
Entrapment meaning it gets stuck.
Literally stuck or crushed in these narrow corridors. There are several main culprits for this entrapment. The first, and incredibly common for women, is childbirth.
That makes sense.
Right. As the fetal head descends through the pelvis, it can severely stretch the pudendal nerve, particularly right at the level of the ischial spines.
Those are the bony protrusions deep in the pelvis, right?
Yes.
I would imagine that any pushing phase during labor would stretch things, but the sources specify that prolonged pushing or tearing or the use of forceps, that increases the risk of nerve damage exponentially.
Exponentially, yes.
Because while a nerve can recover from a mild stretch, a severe stretch can cause microscopic tearing in the nerve fibers themselves. And that microscopic tearing is what leads to that loss of neuromuscular feedback. But childbirth is just one obstacle. What about people experiencing this who haven't given birth?
Building on your heavy door hinge metaphor, imagine applying intense, sustained pressure to those moving parts over time. Pudendal neuralgia is sometimes famously referred to as cyclist syndrome.
Oh, wow. From the bike seat.
Exactly. Think about the mechanics of sitting on a hard, narrow bike seat for hours. You are putting the full weight of your body directly onto the perineum, forcefully compressing the pudendal nerve against the sacrotuberous ligament.
Yikes.
And prolonged sitting in general, like day after day at a desk, can cause similar compression.
And we also have to factor in pelvic instability, right? If the ligaments holding your pelvis together get weak from, say, an injury or hypermobility, your sacrum can actually rotate or shift. Because the pudendal nerve is threaded right through the ligaments attached to the sacrum, a shift in the bones can literally act like a pair of scissors on that nerve.
Biomechanics play a huge role, and we also see iatrogenic causes.
Meaning medically induced.
Right. Surgeries in the pelvic region, especially pelvic organ prolapse repairs or procedures involving the placement of surgical mesh, they can inadvertently trap the nerve, stretch it, or cause dense scar tissue to form around it, which just strangles the fibers.
So we have a vital master cable threaded through a mechanical obstacle course, vulnerable to childbirth, sitting, shifting bones, and surgery. Given how many physical things can pinch this nerve, you'd think doctors would spot it instantly when a patient comes in complaining of burning and vaginal laxity. But the sources reveal a deeply frustrating reality for patients. It's basically a misdiagnosis merry-go-round.
Pudendal neuralgia is incredibly difficult to diagnose because there's no single, definitive imaging or blood test.
Right, you can't just draw blood and see a pudendal nerve marker.
Exactly, and it rarely shows up on a standard MRI. It is largely a clinical diagnosis, meaning the physician has to recognize a highly specific pattern and symptoms, often utilizing a diagnostic checklist called the Nantes criteria.
They might do a physical exam and check for Tinel's sign, right, where they press on the nerve through the vaginal or rectal wall to see if tapping it reproduces the burning pain.
They do, yeah.
But beyond that, it sounds like a lot of guesswork.
The diverse nature of the symptoms makes it uniquely deceptive. Because a patient might present with burning, urinary urgency, painful sex, and a feeling of vaginal laxity all at once. Well, the condition is frequently misdiagnosed.
As what?
In women, it's regularly mistaken for interstitial cystitis, endometriosis, or valdynia. In men, it's often misdiagnosed as generic non-bacterial prostatitis. Patients can spend years bouncing from urologists to gynecologists to pain specialists without any real answers.
The sensory symptoms detailed in the sources are just, well, they're bizarre. There's a specific medical term mentioned, allotriesthesia.
Allotriesthesia is the distinct sensation of a foreign body. Patients with pudendal nerve entrapment will frequently describe the highly distressing feeling of having a golf ball or a tennis ball stuck in their rectum or their vagina.
Wait, but there's nothing actually there.
Absolutely nothing there. But the entrapped nerve is sending a scrambled, chaotic signal to the brain, which the brain attempts to interpret. So it categorizes the pressure as a large spherical object.
Can you imagine going to doctor after doctor for years with the physical sensation of sitting on a golf ball, or the distressing feeling that your vagina has suddenly lost all its tone, only to be told by multiple specialists that your tissue looks completely fine and it's probably just stress?
It's awful.
The psychological toll of that invalidation must be immense.
This raises an important question about how we approach chronic pelvic symptoms and the sheer necessity of self-advocacy. If you are experiencing these confusing issues, you have to look for the specific hallmarks of nerve entrapment to guide your own care.
Like what kind of hallmarks?
Well, for example, one of the most defining characteristics of pudendal neuralgia is positional pain. The pain or discomfort is uniquely worse when sitting down because you are physically putting weight on the entrapped nerve. Crucially, it is often relieved when standing up, or, and this is a highly specific clue, it is relieved when sitting on a toilet seat.
Because the toilet seat has a hole in the middle.
Exactly.
It completely removes the direct pressure from the perineum and the Alcock's canal area. Identifying that one specific pattern, pain that vanishes when you sit on a toilet, could be the key to helping a doctor realize you have a nerve entrapment issue rather than a tissue issue. Okay, so let's say we've solved the mystery. The nerve is damaged, causing the loss of sensation and muscular laxity, and we finally have the right diagnosis. Are you just stuck with a pinched master cable forever?
Fortunately, no. There is a whole spectrum of therapies aimed at decompressing the nerve and rewiring the circuit. The absolute first line of defense is usually pelvic floor physical therapy, or PFPT.
Okay, I have to admit some confusion here, and I want to push back on this. If this nerve is trapped deep inside the pelvis, hiding behind thick ligaments and shifting heavy bones, physical therapy sounds like throwing a water balloon at a brick wall.
I get that, yeah.
Like, how can PT possibly reach a nerve that is buried that deep?
Well, it requires a highly specialized approach. This isn't about doing Kegels.
Oh, really?
In fact, if the nerve is trapped by a muscle spasm, doing Kegels will clamp down on the nerve even harder and make the pain significantly worse.
Oh, wow. So it does the opposite.
Yeah. A specialized pelvic floor physical therapist works internally through the vaginal or rectal canal to manually release and relax the deep pelvic muscles like the obturator internus. If those muscles are constantly spasming, they actively pull the ligaments tight and crush the nerve inside Alcock's canal.
Ah, okay. So it's about taking the tension off the surrounding hinges so the wire finally has room to breathe. That makes sense. But the treatment that completely blew my mind in these sources is neuromodulation. Specifically, transcutaneous tibial nerve stimulation, or TTNS. So what does this all mean? The sources explain that they place an electrical stimulation pad on a nerve down near your ankle, the tibial nerve.
Mm-hmm.
And by sending gentle electrical pulses into your ankle, it magically modulates the pelvic floor, improving symptoms of vaginal laxity and pelvic pain. I mean, treating an ankle to tighten a vagina sounds like pseudoscience. How is that anatomically possible?
If we connect this to the bigger picture, it all comes down to the wiring schematic of the human nervous system. The tibial nerve in your leg and the pudendal nerve in your pelvis share the exact same origin point in the spinal cord.
Those S2 and S3 sacral nerve roots we discussed earlier.
Exactly.
So the ankle is basically a backdoor to the pelvis.
Precisely. And it utilizes something called the gate control theory of pain. Think about what you do when you bump your elbow.
I immediately rub it.
Right. The non-painful sensation of rubbing travels to the spinal cord faster than the throbbing pain signal, essentially closing the gate and blocking the pain from reaching the brain. TTNS works similarly. When the pudendal nerve is trapped and highly inflamed, it's very difficult to treat it directly without causing severe flare-ups.
Because touching it just irritates it more.
Right. But by stimulating the tibial nerve at the ankle, those positive, non-painful electrical pulses travel up the leg and flood the sacral plexus at the base of the spine. The influx of new signals essentially jams the radar, closing the gate on the pudendal pain signals.
That is fascinating.
Over a series of sessions, it resets the hyperactive pain receptors, it calms the inflammation in the pudendal nerve, and helps restore the proper motor signals to the pelvic floor muscles. By fixing the signaling issue at the spinal root, the muscles regain their tone, and the brain starts receiving proper sensory feedback again, which directly improves the sensation of vaginal laxity.
That is just brilliant, using the body's own highway system to bypass the traffic jam entirely. Now, the sources also map out a few other options if physical therapy or neuromodulation aren't enough to calm the nerve. There are non-surgical energy treatments like radiofrequency or erbium lasers.
Yes.
The heat from those lasers can actually stimulate collagen production in the vaginal tissue to add some physical firmness back, kind of compensating for the muscular weakness.
The clinical guidelines also point to more direct medical interventions. Specialists can utilize targeted nerve blocks, injecting a combination of anesthetic and steroids directly into Alcock's canal to chemically calm the inflamed nerve. They can also use targeted Botox injections to force the spasming pelvic floor muscles to paralyze and relax.
Which forces them to let go of the entrapped nerve.
Exactly.
And as an absolute last resort, the sources mention surgical decompression, where a specialized surgeon actually goes in and cuts the ligaments or fascia to physically free the trapped nerve from the tunnel.
The primary takeaway from the treatment landscape is that restoring function requires a multidisciplinary approach. You are treating a mechanical entrapment that has caused a neurological misfiring. It requires patience and a combination of therapies, but tone and sensation can absolutely be restored.
To briefly recap the journey today, if you or someone you know is dealing with vaginal laxity, remember that it isn't always a simple case of stretched physical tissue or aging. It can be a direct, hidden result of pudendal nerve damage. That pinched master cable causes a double whammy, a loss of sensory friction signals reaching the brain, combined with a literal weakening of the pelvic floor muscles supporting the vagina. But by recognizing the unique symptoms like positional pain that changes when you sit on a toilet seat, or that phantom golf ball sensation, and utilizing targeted therapies like internal pelvic PT and tibial neuromodulation, that nerve can heal.
Before we wrap up, I want to leave you with one final, truly mind-bending detail hidden deep in the clinical sources regarding just how adaptable and sometimes frustrating our nervous system is. It's a physiological concept called sacral cord neuroplasticity.
Neuroplasticity, meaning the brain and spinal cord are actually physically rewiring themselves based on experiences.
Yes. When the pudendal nerve is entrapped and screaming in pain for months or years, The constant barrage of extreme pain signals actually physically alters the spinal cord itself at the sacral root level.
Wow.
It creates a state known as central sensitization. Because of this rewiring, the spinal cord starts misinterpreting normal, everyday signals from completely different nerves that just happen to share that same area of the spine.
Oh, no.
The result: during a bad pelvic pain flare-up, you might suddenly feel severe burning pain in completely unrelated areas of your body, like the arch of your foot or your toes.
Wait, really? Your foot physically burns because your pelvic nerve has been screaming so loud for so long that it essentially short-circuited the main breaker box in your spine.
It leaves you to ponder just how incredibly and sometimes infuriatingly interconnected the human nervous system truly is. The pain is in your pelvis, but the alarm bells are ringing in your feet.
It brings us right back to our opening thought. We desperately want the body to be like simple engineering a clean X-ray, showing a clear break. But the reality is a murky, deeply interconnected web of electricity, sensation, and perception. Keep listening to your body, keep advocating for yourself, and keep asking curious questions about your amazing complex biology. Thanks for joining us on this deep dive.